Hi, I'm Jeffrey Popma. I'm an interventional cardiologist at the Beth Israel Deaconess Medical Center in Boston and a professor of medicine at Harvard Medical School. What I'd like to discuss today is the results of what I think is one of the most transformative trials that we've seen here at the American College of Cardiology meeting, and that is the Evolut Low Risk Randomized Clinical Trial, a trial that compared transcatheter aortic valve replacement to surgical aortic valve replacement. As a bit of background, this has been an investigator group that has been forming for the last 10 years. When we first met in 2010, we didn't know how transcatheter aortic valve replacement was going to compare to surgery. We started our initial study with the patients who were extreme risk for surgery and quickly moved on to patients who were deemed to be high risk for surgical aortic valve replacement. In that randomized trial led by Dave Adams and Mike Reardon, we found that in fact for the first 2 years, there was a lower mortality rate with transcatheter aortic valve replacement than with surgery. At 5 years later, presented by Tom Gleason, there wasn't a significant difference between the two, but nevertheless, during that early period of time, there was a mortality benefit associated with use with transcatheter aortic valve replacement compared to surgery. We then moved on to the SOTAVI trial, a trial in intermediate risk patients. And in those intermediate risk patients, we found at 2 years, the rate of disabling stroke or all-cause mortality was not inferior with TAVR to surgery. A very important finding, again published by Dr. Reardon in the New England Journal of Medicine. And that brings us to today. Over the past 2 years, we've been recruiting patients who are deemed by a heart team to be low risk of surgical aortic valve replacement to either transcatheter aortic valve replacement or to surgery. And what do we mean by that? Our heart teams met at all of our institutions. We deemed that the patient was going to have a less than 3% 30-day operative mortality. And if the patients met that criteria, they were enrolled in the clinical trial. We then enrolled over 1,400 patients into this randomized trial, equally divided between transcatheter aortic valve replacement and surgery. We performed this study at the most phenomenal clinical sites across the world, 80 of them, who then used their best surgical approach in those patients randomized to surgery, and their best practice technique for those patients who are randomized to transcatheter aortic valve replacement. We did something I think very important. We picked as a primary endpoint all-cause mortality or disabling stroke at 2 years. And that endpoint was an important endpoint for us because we felt that we needed to prove that there was unequivocal non-inferiority of our transcatheter valve versus surgery valve, because we felt that it was going to change the field, that we had to have an absolutely durable outcome, a hard clinical outcome, something that no one would really dispute. The patients who were enrolled in the study were 74 years old. They had an average STS score of 1.9, which really meant that they were in fact a low-risk surgical group. Here's what we found. We found that at using a Bayesian analysis, when 850 patients had actually achieved a 1-year outcome, we found that extrapolating those results to the entire cohort of patients, for all 1,403 patients, that at 2 years, the predicted probability of death or all-cause stroke, disabling stroke, was 6.7% in the surgery group and 5.3% in the TAVR group, strongly non-inferior and meeting our primary endpoint. But then we looked at a variety of secondary endpoints, and I'll just summarize them. We asked the question, how safe is TAVR? We understand now that the mortality rate was extremely low at 30 days and 1 year in both the surgical groups and the TAVR group. But our pre-specified 30-day safety endpoint was better with TAVR. And what was included in that? Mortality, disabling stroke, atrial fibrillation, acute kidney injury. All those endpoints that we look at from a secondary standpoint were actually better for patients who were treated with TAVR than surgery. What was different? There were more pacemakers in those patients who were treated with TAVR. We've known that. But that was about the only deleterious or downside effect of treatment with that device. And we've got ways, as I'll discuss, to approach that. Otherwise, out to 2 years, there was a significantly lower reduction in disabling stroke, similar mortalities, and any way we looked at the data, we found that TAVR was a preferred option. Now, we did one more thing. We said, let's look at now how often the patient needs to come back to the hospital in the first year. And what we found was that within the first year, there was significantly lower rates of rehospitalization, heart failure rehospitalization, in patients who were treated with TAVR than surgery. So the composite of death, disabling stroke, all hospitalization in the first year, significantly lower with TAVR. So what are the caveats? Well, we didn't put patients in the study who were candidates for mechanical aortic valves. We didn't put patients in the study who had bicuspid aortic valve disease. And in general, as the operations went through, 99% of TAVRs were performed from the transfemoral approach, which means we didn't put many patients in who had very prohibitive iliofemoral access. So what does this mean for our patients? Well, in this large-scale randomized trial with an endpoint of all-cause mortality of disabling stroke at 2 years, we showed that TAVR was not inferior to surgery, a very, very important endpoint for our patients. Secondly, at 30 days, we found that TAVR was a safer procedure with lower rates of disabling stroke, lower rates of acute kidney injury, lower rates of life-threatening or disabling bleeding, albeit at higher rates of the need for permanent pacemakers and for residual aortic regurgitation. In aggregate, patients now can choose between these two different therapies, a lesser invasive approach or a more invasive approach, but probably the evidence falls, in fact, in favor of TAVR. One final point. With this self-expanding Evolut technology that was used for the trial, we found that the gradients were significantly lower at all time points out to 2 years with TAVR than surgery, and that the aortic valve areas were higher with TAVR than with surgery all the way out to 2 years. This resulted in a 4-fold reduction of the degree of severe prosthesis-patient mismatch at 1 year in patients who are treated with TAVR. And these better valve hemodynamics, we think, may have a very beneficial effect on a younger population treated with this device. We hope that these results, now published today in the New England Journal of Medicine, available both in the primary manuscript and in an extensive supplement, will support the fact that in patients who are deemed to be low risk for surgical valve replacement, TAVR is in fact the preferred therapy for the appropriate patients.